Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by Tyto Care. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but also rebuilding it from the ground up. Today, I'm joined by Dr. Brad Anderson, an internal medicine physician and medical director of virtual care at OSU, and by Jared Droze, director of virtual care at OSU Medicine. Welcome.
Hey, morning, Joe. Yep, thanks for having us. We're excited.
Yeah, absolutely.
Great to have you here. So together, Dr. Anderson and Jared are leading a wide-ranging virtual care strategy that spans rural hospitals, urgent care clinics, schools, all designed to help patients in their communities get the care they need closer to home. We're going to talk about how OSU is building virtual care models that actually work in rural communities and what they've learned along the way. So let's get started. Dr. Anderson, Jared, OSU serves a largely rural state, and there's long travel times, limited access points. What, in your opinion, are the biggest access challenges facing patients in Oklahoma, but specifically rural Oklahoma today? And how did that kind of shape OSU's approach to virtual care?
Yeah, I'll go first, and then Brad, I'll let you, Dr. Anderson, I'll let you go. I think, and again, there's we could probably find a really, a big list in terms of all the things. I'll pick one of those out in terms of access, and for us, what's unique, obviously, Oklahoma State University Center for Health Science. Obviously, we have our medical school attached to that, our residency, our hospital. And so for us, it's an opportunity to train and equip physicians to expand out to rural areas. We actually have a lot of rural residency sites, medical rotation sites. Even our PA program has lots of rotations in rural Oklahoma, a lot with obviously our rural hospitals and rural clinics that we put them in those positions, provide them the opportunity, the experience to really, have that rural residency approach. And so for us, when we think of how did we come across that, but not also include virtual care into that, once we blended those two things together, right, we're teaching, we're equipping. So not only are we teaching on virtual care and how that gets carried out and how we do that here within the university, but also how we can create access points across the way for rural Oklahomans and create those spots where we can provide them instant access in a way to internal medicine, to cardiology, psychiatry, you name it, right? All of our specialties that we have. And we'll hopefully we'll get to talk about a few more of those that we're working on today, kind of in the background. So that would be at least one of the many things that we could probably come across, right? Dr. Anderson, go ahead.
Yeah, absolutely. I would just say, Oklahoma is unique in itself in the fact that, it really has two large metropolitan cities, Tulsa and Oklahoma City. Outside of that, the rest of the state is rural, and it's built mostly the healthcare system on these critical access rural hospitals that are really underserved tribal nation hospitals that serve a large population, but just don't have great access. And so Oklahoma State made it part of their land grant mission to try to help those rural hospitals survive. And through virtual care, we feel like we are able to do a lot of that through placing, those highly specialized physicians like Jared talked about in these locations virtually to try to help keep patients there in the community, in these rural hospitals, and keep them afloat so that we have a thriving healthcare system here in Oklahoma.
And Dr. Anderson, this is something we've spoken about before, but the training programs that Jared mentioned, are you finding that by having these robust training programs for clinicians, that is helping those clinicians to stay in that community?
Yeah, I think it just adds another tool to the tool belt, and it adds, increased things that they have to do once they leave their training and have another tool that they could utilize when they're out, on the field. As we have an ever-aging population here in the United States, as we continue to see more patients on Medicare and Medicaid, it's going to be important that we have all these tools to be able to see patients, whether they are, in a rural community or even in an urban community. Being able to use technology to better access healthcare is key to one thing that we want to do and one tool that we want to provide these students, whether it's a medical student, PA student, even down to our nursing students, be able to utilize this technology to better access care to those patients.
Yeah, I'm just going to add to that. It's kind of, it's really hard to recruit some of these specialties as well when you get in a smaller, critical access hospital. It really can be difficult. So for us, like Dr. Anderson mentioned, if we can add another tool to at least what we're doing on the training side, now we've got physicians and PAs that are equipped to know how to handle what's appropriate for virtual and what's not, right? So we can have a good hybrid approach. And so I think that's one of the main things why we include that in our training, and it really does help support them. So
I think that makes so much sense. And something that a few people have mentioned on the podcast is how training that next generation from the beginning to know how to deal with virtual care, how to deal with the technology elements of that means that we've got an entire generation of clinicians coming in who know how to do that. And that hybrid approach will potentially be their first approach to patient care, which opens so many doors and opportunities for the future. You had originally explored kind of a hospital at home model, but you ended up not taking that approach. Why did it make more sense to kind of build a virtual care network, particularly in rural areas? And was there anything that you learned as you built out that original or started to look at building out that original hospital at home model that you then were able to take forward into the system that you've now built out?
yeah, we let's see, this was maybe 3 to 4 years ago, I think. But we originally, like you said, started out with a path to do something with hospital at home. I think it was fairly new at that time, or newer. So I think in terms of our initial assessment, right, at least for our partners in the state of Oklahoma, at the current time, it just wasn't feasible. And so we got some great feedback from rural administrators. And so we our group, our leadership group decided to pivot and do something that again can help sustain rural hospitals. And that's where kind of this virtual care initiative and service line came from. And we were able to obviously give them the kind of that safety blanket, or that very first kind of level of care that we could do, which would be kind of maternal medicine hospitals. How can we support our hospitals, keep patients locally, reduce transfers? That was kind of the main thing, or at least the main theme, I should say, that really has stuck with us and continued to stick with us as kind of our kind of foundation, right? Revenue stays local, patients stay local, families get to stay local. And so for us, that's kind of what kind of took off from there. And from internal medicine, we went from internal medicine to behavioral health and psychiatry, addiction medicine as well with that, and then kind of branched onto cardiology and some others. So, Dr. Anderson, you want to add to that?
Yeah, no, I think, just seeing the need was a big part of it, right? Going out to a lot of these rural communities, these underserved, critical access hospitals, just seeing the need that they need. I think we adjusted our plan and we continue to adjust based on the need that is present in the state and kind of the need that's present in these communities. And so being kind of flexible is key to our overall success over the past years.
And how many hospitals are you covering now with your virtual care?
Yeah, so now we're in around 18 to 20 across the state of Oklahoma, and that includes critical access hospitals, acute care hospitals, even psychiatric hospital as well. So kind of spreading around and tribal affiliations too. So we're very fortunate to be able to spread that across quite a few different landscapes of healthcare. And so for us, it was how can we at least get maybe 15 to 20 right now. And then as we're building to that next phase, we've got a lot of things coming down with rural transformation funding. We've got a lot of different things in terms that we're doing internally to help build. And so we're kind of in a position where we are at least kind of pulling back on that slingshot. We're getting ready to kind of launch the next phase of what we're doing. And so should be exciting.
I love that analogy. Just try not to, I guess, break anything when you let go.
Yeah.
Can you just maybe go through briefly how your program works? So you've got people you've got patients in hospitals, and then you've got clinicians remotely checking them over and deciding if and when they need to be transferred.
Yeah, so I could speak on that a little bit more. One of our big programs that we do is the hospitalist program that Jared talked about. We do cardiology and behavioral health as well. But how that works typically, we go to these rural community hospitals and try to find the need that they have. A lot of times it's, a APP provider being a PA or a nurse practitioner, or sometimes a family medicine doctor who's trying to do both clinic and hospital medicine at the same time, and it's just difficult for them. A lot of times they just ask for a little bit more support on, difficult patients. So we have a, whole host of internal medicine physicians here who have extensive knowledge, including outpatient and ICU level knowledge, so kind of this wide range of knowledge. So we use them to see consults and see patients within these hospitals and help determine if there needs to be a transfer, or if the transfer for that patient may be unnecessary, and they can make some adjustments to their current kind of projected regimen and try to keep the patient there and follow along with the patient. We see them virtually and can assess the patient directly and kind of help determine kind of the next steps for that patient. So it works out really well. A good example that I had is a nurse practitioner called me about a patient she was concerned may need dialysis. There was some concerning lab findings. So I evaluated the patient virtually and looked over all the lab work and the orders, and I made some adjustments. I didn't feel like the patient was quite ready for dialysis. I felt like I could potentially help this patient. I always had that in my back pocket if I needed to get that patient somewhere for dialysis, but I felt like I could potentially help them. So I made some adjustments to the medication, made some adjustments to the plan. That patient was able to stay there at that facility. Actually, they stayed for another 3 or 4 days because they were in a swing bed, so they were getting rehabilitation. So they were able to get their rehab, stay in the facility, able to be discharged from that facility and follow up with a kidney doctor outpatient. So it was a win-win for everybody. Win for the hospital because they were able to keep the patient there. Win for the patient because they were able to stay close to home, close to their family, and a win for us because we were able to keep the patient there in the hospital and not have unnecessary transfers, unnecessary
Yeah.
medical bills that we were able to avert there.
And I think that's what makes kind of what we do unique, at least from the state of Oklahoma, right? So Dr. Anderson, his team, even from behavioral health, addiction to cardiology, we're well aware of, all the referral streams that are there. We know whether that's Oklahoma City, whether that's Tulsa, that kind of that extra layer of support you get is also when is it appropriate to take this patient and put them in the appropriate level of care? When do we need to do a transfer, and how does that look? Again, we obviously we know all the specialties around, even subspecialties that we need to refer to, where they need to go, how we should place them. And so it's a level of support, one, we can give the hospital, the patient, and family that they can trust us. We know where to send them and where to go. And then the other side of that is wherever they're at, we're going to follow that patient. We're going to make sure at the point of discharge, they get back and they get home, right? So whether that's send them back to their critical access hospital where they can go back to a swing status, or they can go, discharged home and get follow up there. So that's the other unique thing I think with us is that we want to make sure we get patients back to their home, back to their hospital where they're at in kind of in town. So
That makes a lot of sense. Are the hospitals that you're providing services at, are they OSU facilities, or are they kind of third parties that you partner with?
yeah, they're all unique. So OSU, kind of the OSU medicine kind of health umbrella or ecosystem, if you will, we've got one teaching hospital that's in Tulsa, and we've got obviously our clinic system. But outside of that, that's it for us, right? We've got obviously our medical school, but all those hospitals are unique. They're all their own entities. Most of them are smaller, like I said, rural facilities, critical access hospitals, or smaller acute care facilities that are all kind of locally owned, if you will, or locally ran with local
Uh-huh.
support there. So it's all very unique. Every hospital is different. Some things hospitals do differently, and depending on the leadership there, they may, like something different. And so everybody gets a little bit of a tailored package when they get us, right? So we're open to having that discussion, and we're very open to having, what does that look like for the hospital, and how do they win in this situation, and then how does the patient win as well?
Right. So you're really looking at like what is going to make that work for that specific facility depending on their needs. And you're
Absolutely.
also
Yep.
looking at the patient, so how it's going to work for them. And I want to talk, you spoke about the patient transfers. Obviously, we're looking at a very rural area. We're looking at potentially long transfer times. I think that when we spoke before, you had mentioned a lot of air transports as well. Um, why do we want to stop those transfers? Why is that essential? And like, what's the feedback from people? I mean, I know from me, I would not want to be in a hospital far away if I can be in a hospital close to home.
Yeah. Right.
But tell me a little bit about how that works and what that looks like specifically in rural
Yeah.
Oklahoma.
I'll give just a general sense, and I'll let Dr. Anderson carry it home. But from a general sense, I think for us, not only when we talk about unnecessary transfers, even transfers that have to happen that need to go, either life flight or you've got one ambulance in a county, and so you don't want to tie them up, right? So for us, the other thing for us is clinical knowledge and expertise. We'll work with a facility to look at their protocols, look at their clinical care and quality. How can we enhance that by coming in and keeping that patient there by doing that piece too? So there's an education component, I think, from our sense that we want to provide and be able to give back in that sense. So we can, again, if we can increase acuity or we can increase clinical knowledge there for that hospital system, I mean, that's a huge win for them and the patient. So, Dr. Anderson.
Yeah, absolutely. Anytime that, we could have some healthcare savings costs by keeping a patient in their current status, whether that's, in a rehabilitation status or in an acute inpatient status, that's key to helping our overall system in healthcare in the United States as well to lower costs, right? But it is very important for patients that they want to stay close to home, close to their family. I do believe that, family plays a key part into us healing and having, a familiar place is important. So anytime I could keep a patient in their kind of home community, I think that's an important part of being healthier and gaining your health back quicker. And then, it's overall important for the hospital to try to keep these patients in their facility because that's how they create revenue and are able to keep open, right? These are critical access points for our healthcare system. So we need them in these communities to stabilize patients and get them to a higher level of care when it's necessary, especially when there's emergency or when there's a necessary transfer. We want that to happen and we want to help facilitate that as well. But if the patient doesn't need to come and could stay there in that facility, it's beneficial to the hospital as well so they can maintain patients in their facility and maintain their revenue overall.
Yeah, especially at this, we're seeing so many of those rural hospitals close, so many of those critical access hospitals shut down. Obviously, keeping that revenue stream within their walls or within their facility is key. Otherwise, we're going to end up with only Tulsa and Oklahoma City being able to serve these patients. So we've kind of spoken about the hospital program. I know that you're also using virtual care inside urgent care clinics to speed up that urgent care process. So what does that look like and how is it improving access to care?
Yeah. So yeah, for us, primary care wise is kind of another service line that we have. And, we looked at this as a way, again, we talked earlier, how do we create access points? This is a great way to do that. When you think of at least rural Oklahoma or maybe rural America, you think of kind of Main Street and some of that, in some areas, again, is kind of fallen off and you kind of see the Main Street dying. So for us, we look at that as an opportunity to take maybe, a building that might need a little bit of enhancement, in terms of facility wise. But for us, how can we take that and make a 1, 2, 3 exam room? Nothing major, but how can we take that and
Uh-huh.
turn that into an access point for an urgent care walk-in clinic where we can do that, provide the clinician virtually, have a nurse boots on the ground and one kind of receptionist to obviously your or patient rep to take care of the patient and insurance needs and all that stuff. So for us, our tribal affiliation that we have in Antlers, Oklahoma, with Choctaw Nation's been fantastic to do that. It's a great opportunity for us that we've launched at least over a year now, or close to a year. Actually, we're getting ready to be close to a year for that. And we've got 2 exam rooms, small lab that we do point of care testing out of that. This town and community is probably maybe 2,000 or less. And so when you look at it from, the
Okay.
county wise, it's really fantastic if you can pull all of this in from folks that might have to travel, you know, 20, 30 minutes to get some healthcare access. And they can do it in a fashion that they can walk in, you don't need a schedule, stop by, and at least it creates that access point where we can see patients virtually of that. It's been great so far. We're enjoying at least the partnership building on kind of that next location in another area. Again, kind of the same setup. Smaller rural town in Oklahoma. How can we create an access point there where they used to have a hospital, used to have a clinic? Now there's not really anything in that town. So how can we provide again that access, smaller footprint, less cost overall, at least operationally? So yeah, Dr. Anderson.
Yeah, I don't have a lot to add to that. That was a good example of how we're doing, access to care in really small communities even that don't have really the ability to sustain a model of, a large kind of urgent care. that would take quite a bit of staffing. So then we could, kind of spread out the provider across multiple different, small facilities that becomes more sustainable at that point.
And we haven't actually kind of spoken about this before, but can you tell me a little bit about, you mentioned your partnership with Choctaw Nation. Is that something that you are providing healthcare services across the entire community? Or is this kind of a one point and where there are more opportunities, then you kind of grow into it?
Yeah, so the partnership with Choctaw Nation is kind of a longstanding one, at least for OSU. We also have another with Cherokee Nation, the first tribal affiliated medical school. And so we have that also. For us, tribal, rural, underserved, that's kind of what OSU's motto is. Obviously, that's our approach. That's our importance when we look at the landscape of Oklahoma. And so for us, kind of deepening that, furthering that with Choctaw Nation's a priority and others. And so we not only do primary care, we also do cardiology clinic with Choctaw Nation. And so we've created a couple of access points that way too. And so working on, kind of different initiatives as well behind the scene, but expanding that to clinic. And then also we do cardiology clinic at least twice a week there with them. And actually it's in a different site, one of another location in southeastern Oklahoma that we provide cardiology service to.
Okay. So you guys have got so much going on in terms of your virtual. So I'm kind of like skipping from topic to topic, but we've done hospital, we've done urgent care. I want to talk about school-based care as well, because obviously that's a very different setting, a very different clientele. Why did you decide that this was a good place to provide care, and what does that access look like? Is it just for the kids? Is it for the whole family? How does that work?
Yeah. So for us, again, creating access points probably where you wouldn't think of it, but inside a school it's one of those really unique opportunities that you can bring, obviously, care to, I would say, families. We see we see just children, right? We see school kids that are enrolled in that district. We'll see them, but I mean, it helps the entire family, parents and guardians. When you think about it, we're able to, kind of assess any kind of acute need, whether that's an earache, a sore throat, minor infection, you name it, fever. We can address, quite a bit of things. And then also for us, I think the main thing that works out well is our ability to loop in the parent virtually for all those visits, whether they are parent or guardian, whether they're home, work, it doesn't matter. They could be on the road like me, obviously in my car, right? Wherever you're at, we can get you connected to make sure that you're part of that visit, number one. And then two, it's an opportunity for us to provide education to, that parent or guardian too. And so the last thing I'll add to that, one of the unique things about the school base is for us to obviously get prescriptions out. If you need an antibiotic or if something that's needed, we can send it to local pharmacy. And if the child's well enough, they can go back to school, right? There's no fever. And maybe they need a little Tylenol to get through the day, but they can stay and remain in school. Parent and guardian gets to stay at work or home, wherever they're at, right? Whatever they're doing. And then they can either go by, pick up that, antibiotic if they need one on the way home before they come pick up, whatever the case may be. So it's been a really unique thing to see. We've even seen some of our schools have resource officers or just other, personnel that, will even go help pick up, a prescription if they need it. All of those things to
Oh,
kind of
wow, that's
help
amazing.
parents and families out. Yeah. We've got one school that is, I think it's like 150 students, very small. They're at least 20, 30 minutes from any type of healthcare access. And for us to introduce that to parents and guardians has really kind of opened up an opportunity to see these kiddos that maybe wouldn't have went to the urgent care or wouldn't have had a chance to be
Right.
seen. And so I think it's, again, a great opportunity to create more access points.
Absolutely. As somebody who has picked up a sick child twice in the last week,
Yeah.
I wish we had access to to the services
Yeah.
Yep.
that you're providing.
Yep.
Yeah, one of the first kids that we saw was a young child who had an earache for 3 or 4 days, I think it was. The parent, for whatever reason, guardian, could not get the child to see a provider, whether it was, cost issue, whether it was a transport issue. I actually can't remember exactly what the issue was, but they could not get the child there. We were able to see the child. We were able to get the child antibiotics. The child didn't have a fever, was not infectious, so they were able to go back to school. But it was able to help everybody out, right? The parent was super thankful for the ability to have that there for their child, and the child ended up being able to stay in school and not have to leave school and not have any further complications of that issue. So
Yep.
overall, a win-win for everybody.
Yep.
I am an internal medicine physician. Never thought I would be doing anything with kids. That wasn't my plan after leaving medical school, but this is one of the best programs I think we do here at OSU, and the fact that we're able to help so many kids just across rural, underserved Oklahoma, including, strep, flu, and COVID testing at some of these facilities.
So that was kind of going to be my next question. And I know that I'm not supposed to ask people to choose favorites when it comes to their babies. But, for each of you, like, how have you seen the biggest impact of these different programs? If there was somebody listening who was like, we want to grow our virtual program, we want to pick one area to expand into. Tell me what your favorite is.
I don't know, Dr. Anderson, you want to go first or you want me? Which one?
Sure. I mean, I really do love the
Yeah.
school program. I think it's, one of the,
Yeah.
most rewarding parts of what we do. Although I love kind of each program in and of itself just because of the cool things we get to do. Oklahoma State gets to have a little bit of a different approach to it just because we are a land grant university, and our ability and our mission is to help kind of these rural underserved, and we don't have to be our goal is sustainability. So there's a little bit of a different goal in the fact that we just want to help these communities and we want to be sustainable. And so being able to work within these programs is just so gratifying beyond whatever I could say, in words. But the school program has kind of a special place in my heart, and our ability to be able to bring testing to some of these schools, which we've done over this past year, I think is just a huge ability, especially strep testing, right? So many kids have strep, and strep can cause, a lot of side effects and a lot of issues if it's not caught early on. So I think it's key to what we do in these schools.
How are you
Yeah.
doing? Wait, Jared, before we get
Yeah.
your
Yeah.
favorite and insult
Yeah.
all of your other children, how are you doing the testing, the on-site testing?
Yeah, so it's right now mostly in schools that have nurses in them. We are in schools that don't have nurses, who may have, a secretary or a front desk worker who does the visits. And a lot of times we don't provide testing to those facilities because we want to make sure we go through all the correct processes and have all the correct protocols and all that. So it is basically based out of schools that have nurses. We do have a APP provider here, one of our nurse practitioners who kind of leads that program. She's able to be kind of the director of these CLIA waived sites at the schools, and they are able to do testing kind of through her seeing the child. She'll see the child and assess them, and then, provide the order for the testing to the nurse, and then the nurse will perform the test. And we're able to get them kind of low cost testing supplies so that we can find these kind of heavy infectious disease, COVID, flu, prior to it causing a problem within the school. And then obviously strep being another important one that we do that needs antibiotics and needs to be taken care of before it causes too many complications.
And then also schools obviously just being the petri dish
Yeah.
that they
Yeah.
are. Like catching
Right.
it with one
Right.
kid, you're kind of
Yeah.
hopefully stopping that knock-on effect.
Absolutely.
Uh, okay. Jared, do you wanna
Yeah.
spill your secret?
Sure, sure. I was gonna say, I mean, again, school based has I think a place in our hearts just because, at least, for me personally, I've got, multiple kids. And so seeing the access points created in a place that, you've heard family members give us feedback about, hey, we're so thankful you guys are here. If you weren't here, I don't know if we could afford to get gas to get to the doctor to pay the copay. I mean, you hear all of those stories, right? And it really means a lot to us. The other thing I'd add to that is we also provide behavioral health therapy in schools too. And so we have an LPC that does
Wow.
that virtually. We had again, kind of the same feedback. We had a family that approached us and said, "Hey, so thankful you guys are here. I've got to take, our 25, 30 minutes away. We've got to go out of school. We got to take them out, travel. It saves us the time to have that resource in school. For us, what's kind of unique is we're able to pull them out, and obviously not a core curriculum hour, but one where it's an elective, and maybe we get to spend 20 minutes. We don't have to do the, 45-minute initial effort for us. We can do a 20-minute if we need, kind of check in with that student. So that's the other piece I would add to that. That's important. And then, I think for us, I think it's our rural hospitals. I think that's the other thing that if we can we've got to keep them open. We've got to keep the support coming for them in whatever way that we can find out and however we can figure it out. There's got to be, for us, that is kind of the core and foundation of what we do is how can we help rural Oklahomans? How can we help rural hospitals stay afloat, and keep serving the patients, keep serving the community? That's that.
Absolutely. And obviously the work that you're doing, particularly with keeping those patients where they are, is having that impact, which is really special and
Yeah.
important. I have one last question for each of you, which is what keeps you both inspired? And I feel like we've kind of maybe addressed a little bit about what you're most proud of because I asked you for your favorites. But what keeps you inspired, and where are you most proud of the work that you're doing?
Healthcare is always changing, right? I mean, it is. If we're not adapting, I mean, we're falling behind. I think for us, the innovation, the creation of new models, I think that's really exciting. How do we match that with the appropriate payment mechanism as well? I mean, there's all different ways that we can do that. A lot of people do that successfully. So for us, and for me particularly, it's how can we find those models that work? How do we get out and do some new innovative things for rural Oklahomans and rural hospitals? I think that's the driver for me is how can we get to that level and how can we create something to help support them in a general sense? I think that's for us, that's what keeps us going. That's why we have school based, why we have hospitals, why we have outpatient clinics, all that stuff. How can we do that? Not just obviously with the tool of technology, but how can we be creative thinkers, innovators for Oklahomans? That's what drives, at least I know that drives a lot of us. So
Yeah, absolutely. I kind of spoke about that with the school-based program, but kind of early on in my medical education, I was introduced to a parable about it's called the starfish parable. So if you get a chance, you should look it up and read it. It's a little long, but it talks about one act of kindness, just one person saved is worth its weight in the whole program itself. And so I think it's key to what we do at Oklahoma State. Even that one child, if the whole school-based program just helped that one child, it was worth it the whole time. And so I think that's what we do, and kind of what our motto is and our mission is to just help people where we can. And even if we just help one person that day, it makes it worth it. And us being able to utilize technology to kind of spread ourselves even across areas that we never thought we could reach, I think is key to how we can continue to utilize technology better to increase access to care. And as we do it, we get to teach our residents, our medical students, our future generation, which is so key to what I do every day, teaching all these students. And I think that's important for us to be kind of a model for these students as they leave here and have those tools in their tool belt. So just kind of wrapping it all up, what I talked about, where we have students, we have medical students, PA students, nursing students who are teaching, and then, being able to use these technologies to increase access to care is key.
Thank you both very, very much. I think one of the things I love most about hosting this podcast is, sometimes I'm on the emailing side of healthcare, and getting to speak to you and hearing what you're doing is also inspirational for me, and I hope it is also for our listeners. Thank you both so much.
yeah, thank you for having us.
Yeah, absolutely.
Thank you. If you did enjoy today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every couple of weeks. And you could also share this episode with a colleague who is passionate about digital health access or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.